A very good morning to all. At the outset, I would like to thank AIOS and our esteemed panel for giving us this opportunity to talk on epithelial mapping and stromal mapping. Now, these were two different topics, epithelial imaging and stromal mapping, but we did heard from Sneha's talk that how topography is important. And with this map, I will let you guys know that why epithelial and stromal mapping go hand in hand. So why is epithelial mapping important for a refractive surgeon? We do have this indices. Now, if you look at this topography, there is a steepening present superiorly, but inferiorly, it's a flat area. It's a very extremely thick cornea of 544 microns. In the inferior zone, there is again, the anterior curvature is flat, little bit of posterior elevation present, but on the elevation back, but this is absolutely normal. And bad D is 2.12, but the biomechanics again is within normal limits. So what are we missing here? Is this a case of keratoconus, or are we seeing a masquerade here? What would you do for this patient? This patient came for a treatment of cross-linking. We do have all the tools like Pentacam, Cirrus, Galilei. They all have their own indices for detecting identifying the suspect keratoconus. But are these adequate in modern day refractive surgery? As I mentioned, that we need to identify the masquerades. Whenever a current day topographer we are seeing, what we see is, or what it measures is the surface. But the surface, the true surface can be masked by the epithelium. And your true surface can be irregular like how you see here. So what we should be measuring as a refractive surgeon should be this surface and not this surface, because if you operate on such an irregular surface, post-surgery you might land up in a big problem. So the question here is, do we have a perfect tool to measure epithelial mapping? Yes, a lot of tools give us, but what about the stromal changes? Are any of the tools giving stromal mapping? These are the tools which gives you epithelial mapping, Visante, OCT, RTView, Cassia 2, and the newer one is MS39, which significantly impacts the safety and efficacy of refractive surgery and also allows for significant improvement for therapeutic procedures. And what I'm going to be talking about is MS39, because it's a combination of both epithelial mapping and stromal imaging, and we do not have any financial disclosures with the machine. It's just purely based on experience. So it's a Placido plus OCT-based hybrid topographer. What does it do? MS39 actually decodes. It actually subtracts the epithelium from the two surface, and it also gives you the anterior elevation and the stromal elevation. Any topographer will give you anterior and posterior elevation, but here what you get is stromal elevation, which is the true surface of your cornea. Now let's take some few case examples. This is a patient who came for refractive surgery, -2 dioptric spherical, no cylinder, 6/6 vision, bad D, CBI, TBI are absolutely within normal limits, and no posterior elevation. If you see the MS39, this is the epithelial thickness, anterior elevation, stromal elevation, and posterior elevation. There is a little bit of epithelial hyperplasia present in the inferior area. The superior region, which you see the flat area here, is around 50 to 52, and the inferior region is 57. So there is a difference of 5 microns in the superior and the inferior zone. And the literature published suggests that if there is a difference of 5 microns or more, that means there is an irregularity present. And if you see here, the anterior elevation is showing as abnormal. Yes, it is because of the epithelial thickness. But the stromal elevation and the posterior elevation are absolutely normal. That's why the indices are normal. The biomechanics is also normal, and these are the indices which are given by MS39. It also classifies it as normal. So we do have, this suggests that this is a case of not a suspicious topography, but a case of inferior epithelial hyperplasia, where you have to treat the ocular surface and not just treat them as a keratoconic eye or a formfrous keratoconic eye. Now let's go back to this example. As I said, this patient had come with blurring of vision, both eye 6/9 parts, and somewhere else diagnosed as superior keratoconus. This is the topography we've already seen. Now let's see what MS39 shows. If you see here, the epithelial thickness in the superior zone is 63, and here it's 41. So there is a gross difference of 22 microns, which might be impacting to such a different curvatural changes. Anterior elevation actually in this area is flatter. There is no posterior elevation, stromal elevation present, and there is no posterior elevation present as well. So I'm not saying this is an absolutely healthy or a normal cornea, but this is definitely not a keratoconic eye we are treating. So we should not just jump in and go ahead and do a cross-linking. We should just treat this patient with artificial tears, probably a sodium hyaluronate based, and put them in cyclosporin, do a thorough ocular surface check, and see if we are missing out on any ocular surface changes. And if such are present, you need to treat the patient for the same. And you also need to rule out in such cases any past history of VKC or allergies, because any past history of VKC or allergies can also lead to superior epithelial hyperplasia. Now coming to mystery of progression. Dan Reinstein group et al. And everyone has published that, everyone have published that in keratoconic eyes, the epithelial will become donut-shaped. This is a C-shaped, whereas in the advanced case, in epithelial, in keratoconic eye, it becomes donut. So profile in keratoconus patients, it's extremely known. And the donut shape, you will find the donut in the area of the cone area. So let's see this case example. This is a corneal topography. This is the baseline topography, and at 4 months, there is a progression noted here. Let's do an epithelial mapping. Here you see there is no donut shape present, but yes, some semi-donut is present. And on follow-up, it has become a donut shape, which is compensatory hypertrophy. And of course, if you see the stromal elevation, it is present here. There is a stromal elevation. So this is a true progression, and here you would like to go ahead and do a cross-linking. But this is the case report where this is a patient where it has progressed, okay? Both the eyes, this patient was kept under observation in view of grade 1 keratoconus, but on follow-up at 8 months, patient had progressed. So we label the patient as progression. But just for our interest, we went back and just saw the epithelial mapping and the stromal elevation. The first line shows the epithelial mapping, and the second is stromal, third is posterior elevation. If you see here, this is the first visit, and this is the second visit, and same thing for the left eye. The epithelial has actually become a little bit thicker here. But if you see, there are no changes on the stroma. Here it's 18 and 13, here it's 17 and 13. At a follow-up, there is no change in the stromal elevation. And same here, there is no change in the posterior elevation. And same we note in the left eye as well. So probably here we are not looking at a true case of progression. Probably the epithelial remodeling is masquerading as progression, and that is why probably this patient is known as is labeled as pseudo progression, and that's when we can treat the patient on sodium hyaluronate based drops, Trehalose, keep them under observation, telling them about the prognosis and explaining it to them that yes, this is why we are keeping you under observation, but in future if it again progresses and if there are changes at the posterior stromal elevation level, then you will require a cross-linking. So that is what we do. So to summarize, epithelial mapping and stromal elevation, yes, it does tell us the true picture, and it also helps us in identifying an unhappy patient from a happy patient. Thank you.
The epithelium is very important, and most people do not look at it because they do not have devices to measure the epithelium. I think the maximum work done on this is by Dan Reinstein, and he actually used, of course you didn't mention that for epithelial measurement, but the ARC scan is has the highest resolution, which is an ultra high frequency UBM, and that gives, of course, whether you should use a UBM or an OCT, there are a lot of reasons. There's a very nice conversation in JRS between Dan Reinstein and John Kanellopoulos as to which is better. But then, of course, with the MS39, it's a high resolution OCT. If you use a lower resolution OCT, then you may not get adequate data. With the MS39, the resolution is, I think, 3.8 microns. So it is quite good for epithelial maps. It also gives abrasions in the epithelial layer, change in abrasions, which you can look at it when you separate the stroma. The only thing is you should look at the fit, in the sense that the best fit surface for the epithelium and for the stroma can vary, yes, especially if there is a change like keratoconus. But if you take the same best fit sphere, then that's a fallacy. So and also I think we need to look at the repeatability, because epithelium is an extremely sensitive so that is tissue. One thing. When do you take the epithelial maps? You should probably, if you're going to do serial mapping, you'll have to take it at the same time of the day, because morning to evening you can have some difference in the epithelium. Also, you should not use any topical anesthetic. You should not do applanation tonometry, because all this can affect your epithelial thickness. And the other thing with epithelium is superior keratoconus. You showed that case. It's not only the ocular surface. Most of them have lid issues, And because of the lid issues, it translates onto the epithelium. So when you have superior keratoconus like that, always examine the lid. There can be a lid deformity or there can be papillae in the lid which can cause this. So looking at the lid is very important when you're interpreting the epithelial maps.
Thank you, sir. Yes, sir.
Mentioning that asymmetrical epithelial mapping to treat the surface inflammation using trihalose. It's a saccharide, it can again increase the epithelial thickness.
So that's also with caution, and which is published in that paper, that trehalose is basically an autophagy inducer. So you have to use it with caution. If there's a lot of allergies, then you can use it because it's an anti-inflammatory as well. But if your patient doesn't have allergy, then try not to use trehalose. It can swell up yes, it can swell up. So the second case where I showed the epithelial masquerade, we had used trehalose. So that's when it led to epithelial hypertrophy, and that's why it was showing as pseudoprogression. So in those kind of cases, if you're keeping on watch, maybe a normal lubricant with a cyclosporin or, yeah.
And the other thing is that the epithelial maps which you get is basically elevation maps. So don't try to compare it with curvature maps. Okay, when you look at stromal elevation, they are elevation maps, they are not curvature maps. So don't compare a stromal map with a curvature map. You should always compare it with the elevation map.
Thank you, sir.